Okay, some urology topics that are tested on the shelf, and I know this is annoying, but it's just stuff that we've got to touch all our bases, and I hope that I'm covering some things that maybe you all may not have had time to get to otherwise, and I hope that you find that helpful. So let's say you have a patient who is described in the question as seeing some red urine, and they're concerned because there's blood in their urine, but they didn't have any pain, they don't have signs of a kidney stone or anything, and they don't have any dysuria. So it's just painless hematuria. And anytime you hear painless hematuria, that's a buzzword, and you should start thinking about bladder cancer in that case. All right. So anybody who comes in with painless hematuria needs to have a cystoscopy, and that's just you stick a tube in through the urethra and you take a look at the bladder, and that's the first step in working it up. However, uh, painless hematuria can be not just due to bladder cancer, it could be due to renal cell carcinoma or any cancer along the urothelium. So these people need more than just imaging with cystoscopy because that only gets the urethra and the bladder. They also need imaging of the upper urinary tract, which would include, well, it could be done with a CT of the abdomen or with intravenous pylography, but CT of the abdomen is usually the better answer. So in a case where cystoscopy is already mentioned in the question, they've already done it, and they say, what's the next best step now after a negative cystoscopy? Then CT of the abdomen would be a good answer. And that may not be something they expect you to know, but I do know that choosing to do a cystoscopy in somebody with painless hematuria is always the right answer. And know the risk factors for bladder cancer in general. Smoking is a big and good one there. That's the number one risk factor. And then industrial exposures, man, I just can't even think of specifically what they are, but usually they mention the patient worked in some kind of a factory or cotton wool mill or something. I don't know, but when I hear they worked in some kind of weird environment and they're talking about the urethra, bladder, it sounds like a bladder cancer risk to me. Just like when you hear somebody worked on a ship or a wood yard, you assume they're talking about mesothelioma risk if it's a lung issue. So then cystitis. So there's cystitis from the acute infection that we'll talk about in a minute, but we're going to talk about two other kinds of cystitis that are non-infectious. So hemorrhagic cystitis associated with the use of cyclophosphamide, and the key here is somebody who has hematuria that's painful. And just remember, it's a step one pearl, but you can prevent hemorrhagic cystitis in patients getting cyclophosphamide by giving Mesna, and they can also practice frequent voiding so that they don't let their bladder fill up. That also helps prevent it. And I think it's important that you know this for the shelf that long term, people who have recurrent bouts of hemorrhagic cystitis have an increased risk of bladder cancer. So then now, interstitial cystitis. This is a really interesting diagnosis. They really have no idea what it is or what causes it, but it's one of those chronic pain syndromes, and the characteristic finding is somebody who has pain when their bladder fills up, and the pain is improved by voiding. Anytime you hear bladder pain improved by voiding, slam dunk, it's interstitial cystitis. So we have to do a cystoscopy in these patients because a lot of them have hematuria, and because interstitial cystitis is actually a diagnosis of exclusion. You can't wave a magic wand and just tell everyone they have interstitial cystitis. You have to make sure there's not a more organic pathology inside their bladder causing the pain. And then some of the presentations for this can be pretty animated on the exam. So they could have suprapubic tenderness that you might expect with a cystitis, or they could tell you that they're getting a pelvic examination and they put the speculum in and the patient was just screaming in an agony. And it almost sounds like a cervicitis or an STD, but they don't have risk factors for it. Patients may also have loss of libido and dyspareunia. And unfortunately, this is more common in females, so I'm not generalizing in general, but these exam pearls here usually will hold true on the test for female patients because that's who usually gets this. And then the treatment, this is always going to be the answer from what I understand, amitriptyline. If you think someone has interstitial cystitis, give them amitriptyline. Now the prostate. Apparently, America does not care anymore about people getting prostate cancer, so we do not screen for it. We do not even recommend doing digital rectal exams, from what I understand recently. So, question asks you, should you do a PSA to screen for prostate cancer? You say, I do not. So, you can have an educated discussion with your patient about it, and that would be the correct answer, to have an educated discussion. So let's talk about BPH, benign prostatic hypertrophy. Symptoms are the ones that we're all familiar with, where the patient wakes up a lot at night having to go to the bathroom, they have trouble getting their urine stream started, the stream stops and starts, and then they stick the finger in there and it's enlarged and smooth on exam. There's no hard nodule, there's no suggestive malignancy nodule type thing. And know that for each patient with this, at minimum, you have to do a urinalysis, check their creatinine to make sure they don't have renal insufficiency, and you do measure a PSA level in these patients. Okay, and let's say you have somebody who's got normal renal function. They can be treated with an alpha blocker like tamsulosin or Flomax because they have a going problem. And so you may have also heard about the 5-alpha reductase inhibitors. And from what I understand online is that the alpha blockers are preferred at this point over finasteride. So if a question asks you which one to start, you should always choose tamsulosin or another alpha blocker in preference to finasteride. You could use them together, however, for somebody who the alpha blocker was not good enough for initially. So you need to know the complications and when people need to be referred. So if somebody has renal insufficiency, or if they have signs of hydronephrosis, or if their bladder's constantly retaining urine and they're getting recurrent urinary tract infections, they need to be sent to urology, and they probably need to have a transurethral prostate resection. So bladder retention is a fun topic, and it's something that I think is very testable on the IM shelf. Somebody who has either multiple sclerosis or stroke, some kind of neurologic damage affecting the CNS, or BPH, and medicines. These are all different things that can cause acute retention of urine. And then you got to know kind of what medicines could lead to this. So someone who takes Sudafed for a cold, or phenylephrine is another name for that, or anybody who is taking Benadryl, or a lot of the antipsychotic drugs have anticholinergic effects, and any medicine that is an anticholinergic in general can cause urinary retention. So this is as good a time as any to go over the difference between an upper motor neuron and lower motor neuron, bladder and incontinence, and how that works. So someone who's got an upper motor neuron lesion in the spinal cord of the brain is going to have issues with urinary retention, or neurogenic bladder retention. These patients usually have overflow incontinence, and that's a difficult thing to recognize on the exam. And the best way I could describe it to you is somebody who has a constant leakage of urine, or somebody who has intermittent leakage of large amounts of urine. But the key to that is that when they leak that urine, they don't have an urge to do it. So they just leak urine with no urge. That's in contrast to somebody who maybe has diabetic neuropathy, or injury to the peripheral nerves, a lower motor neuron injury. Those patients are really not going to be able to fill up their bladder. Anytime any urine gets in the bladder, it's going to stimulate the detrusor, and they're going to have urge incontinence. They feel a little bit, and I got to go to the bathroom, and they're constantly running to the bathroom. So now maybe we've covered that adequately, but those can be difficult to separate, so I hope that's helpful. Multiple sclerosis should always cause an upper motor neuron picture with retention. So how do we diagnose this? This is the fun part, is that on the exam they'll give you somebody who maybe has multiple reasons to have bladder retention. Somebody who has BPH and they just took a Sudafed. Well, bing bang, there's your answer. But we could do a bladder ultrasound, but you don't have to. In fact, the best way to diagnose this is to put in a urinary catheter and drain their bladder. And if they show improvement and you get a bunch of urine out, then you have your answer. So for urinary tract infections, we'll breeze through this really quickly because I think it's mostly in UWorld and it's fairly straightforward. But somebody who, a female, not a male, because if a male has cystitis, that's complicated automatically. But a female with cystitis, shouldn't really have a lot of fever. They have pain with urination, frequency and urgency, and they might have some tenderness in the lower abdomen. And then your urinalysis could show leukocyte esterase from white blood cells. And if it's nitrite positive, then it's probably E. coli or another one of the enterobacteria family. However, if they had a UTI like this and they were leukoesterase positive but negative for nitrites, then they probably have staph saprophyticus, which is actually the second most common cause of UTIs overall. So don't be fooled. Negative nitrite, oh, this isn't a UTI. That's on the contrary, it still could be staph saprophyticus. So keep that in mind. Know the treatment for an uncomplicated cystitis, which could be either nitrofurantoin for 5 days or Bactrim for 3 days. Now, pyelonephritis should be a much more acute presentation. They can have everything that a cystitis patient has and even have a preceding cystitis, but the key to pyelo would be CVA, flank pain, pain with knocking on the kidney, CVA tenderness, and the big one here, they should have a high fever and chills suggestive of sepsis or at least transient sepsis. And one thing that is really emphasized the more I read about this stuff is that somebody with uncomplicated cystitis doesn't have to have a culture. They can just have a urinalysis itself. No culture needed. But with pyelonephritis, we have to get a culture with the urinalysis. So patients who are stable and people who are not vomiting, we can give outpatient treatment to with ciprofloxacin, and that's it. Somebody who's in shock and is really septic or is vomiting everywhere needs inpatient IV antibiotics, and we can either give we give Cipro. I've read multiple things. You can give Cipro alone, or you can give Cipro and ceftriaxone. I think on the exam, I'd pick both, and I would for sure probably do ceftriaxone, but that's just me. So you'll have to face that bridge if you have to come to it, but I'd pick ceftriaxone over Cipro or both. And this is a good high yield point, is that old people, nursing home patients, demented patients, if they develop new onset incontinence, you should be very suspicious that they have a UTI or if they become delirious. And in addition to a urinalysis and culture, you should get a blood culture in these patients. So that's a point that I think you should know, and I think it might get you some free points.